Hello, Protruserati. I'm Jaz Galati, and welcome back to another episode of the Protrusive Dental Podcast. On this episode today, we're talking about something called the Direct Composite Splint Technique for managing cracked teeth. Now, if this is the first time that you're coming across this, it is a completely alien, weird, crazy concept. Like the first time I came across this, our natural instinct when we're managing cracked teeth is to take it out of occlusion, right? You see a crack, let me remove it out of occlusion. But what this technique actually does is the opposite. It actually puts that same cracked tooth in SUPRA-Occlusion, right? And by doing that, by wrapping some composite over the cracked molar, let's say, basically prevents the cusps from flexing and therefore maintaining the crack rather than allowing it to propagate. So that's how it works. And then to even add to the controversies of this technique, what happens over time is that that composite is left in the patient's mouth over the offending tooth, the cracked tooth, right? And then what happens over time is what we call relative axial movement. So that tooth, which is proud in the bite, eventually over time is no longer proud in the bite, and suddenly it's almost pretty much in the patient's maximum intercostal position, so that when you remove that composite, you now have restorative space. Now, if I've gone too fast there, don't worry. We've got a whole hour or something with two leading experts on this technique. So if you're listening, if you're one of my buddies listening from the USA, from across the pond in Canada, maybe you need to sit down for this one, okay? Maybe grab a stiff drink, because this is going to really challenge some paradigms that you have. But I think that's the beauty of dentistry. There's so many different ways of doing it, and this is a very minimally invasive way of managing cracked teeth. So I'm not going to blab on too much about this technique because we've got a whole episode on that. I will give you the protrusive dental pearl for today though. It is, it's an obvious one, okay? We're dealing with cracked teeth, we need magnification. So the reason I'm putting this pearl in now for episode 98 is one of the top 5 most common questions young dentists ask me is about magnification. And specifically, it's like, hey Jaz, do I go for 3 times or do I go for 5 times? Or do I go for 5 times or do I go for 7 times? The answer is super simple, okay? You need to go for as much as you can and as much as you can afford. Magnification is like a drug. I say it over again, it's like a drug. You want more and more and more. I'm on 7.5s now, and I do everything with it. I even do children's checkups with my 7.5 magnifications. It does not leave my face, and I love it. And if there was, like tomorrow, if the same company I bought my loops from released a 10 times, I'd probably get it, right? Yes, there's a whole thing about, maybe the next step is a scope. And I've tried a scope and I enjoyed using a scope, but in my surgery at the moment, it's just not feasible, it's not possible. And also the whole thing about being an associate with a scope and that kind of stuff, which I totally respect. I know some associates have their own scopes, which is awesome. But talking generally speaking, most of us will have a good pair of loops. So the pearl is, get the largest magnification you can afford and you think you can sustain. So if you are deciding between 3 and 5, go for 5. If you decide between 5 and 8, go for 8, go for as much as you can. One tip that Pascal Magnier shared at the BACD conference recently is, and he shared it based on the findings of a paper, is the probe itself, a sharp probe has got the ability to feel a resolution of 40 microns. Okay, that's like the resolution of a sharp probe, whereas our human eye is at 200 microns. 8 times magnification is at 25 microns. So when we're dealing with cracked teeth, you want to use something with a resolution ideally superior to your sharp probe. So that's just another reason to go for as much magnification as possible, and you will adapt. Don't worry. I know many dentists are concerned or worried about not being able to adapt, but I think you will. I think almost everyone does. And usually most people regret the fact that they didn't go for higher magnification. So in a nutshell, go for the highest magnification. So important, especially when we're looking for cracks. Anyway, let's join our guests, Dr. Subir Banerji and Dr. Shamir Mehta, who are absolutely brilliant pioneers in this field of managing cracked teeth with this technique. They've contributed to research in this as well. So the papers, of course, will be on the blog and on the Protrusive Dental Community Facebook group. I'll catch you in the outro. Welcome everybody to this very rare live Protrusive Dental podcast. Today I'm joined by Professor Shamir Mehta. So congratulations on your professorship. We'll talk about it in a second. And Dr. Subir Banerji, 2 absolutely great people in restorative dentists. And I'm really excited to share what they have today about the Direct Composite Splint Technique for managing cracked teeth. Let's start by welcoming our guests and give them a warm welcome. Professor Shamir Mehta, tell us about yourself, where you're working at the moment. Tell us about the PhD that you told me that you recently did. What was that on?
Thank you, Jaz. It's a pleasure to be involved with this podcast. So My name's Shamir. So I do a number of things. I'm a practice owner in Northwest London and do a little bit of practice. I'm the senior clinical advisor to the GDC, largely with fitness to practice. I am Subir's deputy with the MSc in aesthetic dentistry at King's, which we've been working together on since around 2009. And more recently, I've been appointed a professor in aesthetic dentistry at the College of Medicine and Dentistry, which is with the Ulster University. So it's a bit of a varied week. I've recently done my PhD in toothware in Nijmegen as part of the Radboud Toothware project in the Netherlands. So that's me, Al.
Yeah, well, I've seen so many of your publications, including Dental Update and a few papers that are very, very practical, very helpful things that you share all the time. So very, very excited to share those nitty-gritty little details with you. Subir, I was just telling you before we hit the record button that I'd seen you lecture in a small room in a pub in Twickenham in about 2013, 2014. You inspired me that evening, showing me what's possible with composite resin. I've seen you in even bigger stages, the BDA, on a massive big screen showing your beautiful work. Tell us about where you work at the moment. How much teaching do you do, and a little bit about yourself in general?
Oh, thank you very much for a very kind introduction, Jazz, and I'm admiring your mastery of the technology, I have to say. And my actually bread and butter is in general practice. I'm not in Ealing. I've actually been in the same practice ever since I qualified, so I've kind of been there ever since. So that's where my bread and butter is. As far as my academic area is concerned, I've been teaching at King's for about just over 20 years or so. I used to teach on the prosthodontic program, then I'm the director of the MSc Aesthetics program that Shamir mentioned to you. And I've also got my own private teaching academy, the Academy of Dental Excellence, on which we run some diploma and master's courses for restorative and aesthetic dentistry. I'm an associate professor at the Department of Prosthodontics at the University of Melbourne in Sydney. So I've been kind of very varied background academic. I've always been partly an academic, but I have to say my bread and butter is in practice, in general practice, and that's where my passion is mostly. And yes, I do remember meeting you in the pub, which is kind of likely location to find me mostly, but but not all the time, I hasten to add. But yes, I do remember that.
Subir, are you a cricket fan?
I'm a big cricket fan indeed, yes, and I used
because I remember you were running this occlusion course together with the IPL, and I just love that concept, which really caught my eye at the time. Did that ever go ahead, or did COVID get in the way?
COVID got in the way of that one. The idea was to actually hold an occlusion course and a restorative course in Mumbai. And at the same time to actually combine with some the Mumbai Indians fixture, but then COVID got in the way. So we might relive that at some stage late in the
future. Please, Subir, do that. I will support you fully with that. I will come and I will get as many of the producers to come with me as possible. I'm a huge fan of cricket. It was good to see India win today. I'm sure you watched it as well. But yeah, so we could easily spend the whole podcast talking about cricket, but we won't, because today we're talking about the direct composite splint technique for managing cracked teeth. So many people listening, watching right now, will never have heard of it. Some people will have seen it and heard of it and thought, what the hell is this? That was my initial reaction, no offense, when I first saw this. Like this, it just seemed very counterintuitive, right? But then when I actually did it myself in practice and I saw that, hey, actually, this is pretty clever. And then some people may be well-versed in it. In fact, Zain sent a question in, which I'll ask later. So he's been using it and he's found a few challenges with it. So we got 3 or 4 different groups of listeners and watchers. So let's just start with the very, very basics. Either of you wants to go first. What is the direct composite splint technique?
Well, I'll let Shamir answer that one, actually. Go.
Well, it's a technique that actually evolved. We were just discussing before the session. I used to see a lot of cracked tooth syndrome in my own practice, and it used to cause me a lot of difficulty in that, diagnosing it was a challenge, treating it was an even bigger challenge. And, many years ago, Subir and I both used to teach in primary dental care at King's in Denmark Hill. And I remember one Friday lunchtime, I was sat with him and, asked him, how do you go about managing this? It's really, really difficult. And then, we got chatting and, how about this? And essentially what this technique is, it's a minimally invasive way of managing cracked tooth syndrome. And this technique involves placing composite resin over a tooth, like an onlay, if you like, in supra-occlusion. And it can be used before it's bonded to help diagnose the condition. And then it can be used to help manage the condition as well. And the beauty of it is that where it's successful through the process of the intrusion and extrusive movements that take place, it creates the room to put a definitive restoration without having to do very much by the way of any reduction to the affected tooth. So it's a way of diagnosing cracked tooth syndrome and treating it.
Let's explore that, because what you've covered there is in a beautiful way, very short way. You've covered the whole technique. Let's break it down into its individual components. The diagnosis of cracked tooth syndrome is a challenging thing in daily practice. Sometimes the pain is difficult to localize. We often rely on biting on cotton roll or biting on a tooth sleuth or something like that. Do you still do that as part of your protocol, and then you maybe would then use the direct composite splint, or would you nowadays go straight for the direct composite splint on the tooth that you suspect may be exhibiting the signs or cracked tooth syndrome? How would you go about your decision making and sequencing?
Sorry, I was just going to say, Jazz, you raised a very important point there, in that, in practically that's the challenge, isn't it, to diagnose it. And then pretty much when you want to manage it, you want to do something that is not intrusive or not invasive, so that if for any reason you got your diagnosis wrong, you haven't done anything to the tooth. And primarily when you look at ways in which you actually manage it, they do involve a little bit of reduction and therefore putting for example, band around it and something like that. So there is that aspect of it. And from a general practice point of view, of course, when you've made that decision to actually do that, it's you've made an irreversible change in the tooth. The other thing I think it's important to emphasize is that unlike osseous tissue bone, for example, when you put two bits of bone together and you hold it still enough for long enough, then they fuse back together. The fracture mends. But a fracture in a tooth does not fuse back together again. It is there and is there forever, and it will only increase, never decrease. And so you always manage the situation and to get the result from it. So when you come to the diagnosis, one of the things you have to remember is that you do have to have a technique whereby you want to minimize increasing the crack that you already may have in a tooth. And albeit that it's difficult to locate, you need to be very careful in the history taking, try and locate it as best you can, and try and arrive at a diagnosis by minimally putting a pressure on the tooth. And so when you have a tooth, for example, that you're suspecting that is kind of giving a little sharp pain on recoil, for example, on cotton wool roll or tooth, my preference is cotton wool rather than a tooth sleuth, because I find it a little bit harder, because you don't want to put too much pressure on it, is that when you use it at the diagnostic stage, as Shamir pointed out, where it's unbonded, the response that you're looking for is that you put the composite over the occlusal, the lingual or the palatal and the buccal, and then you ask the patient to bite and release. And what you're really looking for is a complete elimination of the symptom. Okay, so basically, before on release on that tooth, the patient might have reported a sharp response. And now that when you put it on a diagnostic level, it is completely gone. Because if it hasn't, then it is usually indicative that the crack is a little bit further or deeper than this technique that perhaps would allow you to control it with. But that's one of the things that I would sort of emphasize on it. And then, of course, this also helps the diagnostic process, because if it actually completely disappears, then you kind of know that by providing some sort of cuspal protection and prevention of flexure, you're able to get the management starting. Sorry, Shamir, I interrupted you at the very beginning of this.
No, I would have pretty much said the same thing, in that I still would start off with a history and look for, the classic sort of pain on biting or release and the sort of acute thermal sensitivity to cold. Of course, there may be other things as well. I still do use a tooth sleuth. I know that there are, sort of issues with the risk of breaking things with it. And I think that has happened to me once. So that there is that risk. But then I would then apply that trial splint as Subir described, and then repeat the same test with the tooth sleuth to see if there has been resolution. Obviously, you're looking at the patient's feedback. And I think the beauty of it is that there are so many conditions which could be quite easily confused with cracked tooth syndrome, that this kind of does help in that, if the pain still persists with this splint in place, it just gives a further sort of level with helping to ensure that you've got the right diagnosis, because I think it is quite easy to get it wrong, with there being so many other things which could manifest in a very similar way.
And of course, the other thing to add to that, I was going to say, is that the evidence shows that when you have a fracture, as soon as you put a burr to it or you take any reduction of tooth, there is a high probability, around about, I think, 26% of teeth then going into the sort of endodontic exposure, endodontic requirement, pulpal intervention. So when you have a technique whereby you don't actually have to open the tooth up, there is that advantage and with it. So that was essentially a conservative way of managing something in the process, which could be applicable in general practice.
Very much so applicable in general practice, I think. I think the way you've designed it and the studies that you've done and the protocols that you've written about, which I've read, are very much quick and easy to apply once you know. And that's what this podcast episode is about, is that disseminating that information, making it easy for general practitioners tomorrow to be able to utilize the DCS technique in diagnosis. So, is this a cracked tooth? And if you make that blob of composite, for want of a better word, over the tooth, compressing the cusps and containing it, and then when they give a negative response, you can then confirm with some relative accuracy that, okay, this is a cracked tooth here, and it was that tooth in question. But that same composite, how many millimeters are you aiming for in terms of thickness? And is it that same composite then you're bonding onto the tooth? And if so, how?
Well, here you might find a different opinion between myself and Shamir, but saying in my personal experience, what I tend to do is use a sort of round about a millimeter on the occlusal thickness that I'm using. Now, do I use the same one? Often not, because sometimes I'm trying to do this very quickly on the diagnosis front, so it's not very neat. And when I've completed the diagnosis and the symptom has completely disappeared, then I would look for approximately about a millimeter occlusally and then go around the sides. Now, one of the aspects that I feel is important, although there has been evidence to the contrary that I have read, whereby to keep this supra-occluded tooth out of lateral excursions, my preference at the moment is still to have it out of lateral excursions, contact. So essentially, if I can add a canine rise to actually lift that out of lateral excursions or any excursive movements, that would be my preference. Rather than having any lateral load. So it's essentially an axial load on the tooth as far as is possible. And I use sometimes a millimeter and sometimes even less than that for this phase. I don't know, Shamir, what you feel, but I think you wanted a bit more than that on the occlusal, did you? Or?
Yeah, so for the trial one, I would probably use approximately a millimeter, as you described, sort of flat on the occlusal surface, wrap sort of 1/3 of the way down the axial walls, buccally and lingually or palatally. I've never never rebonded the same thing back. So I would always make a fresh one. My skills with composite artistry are not to the same level of Subir, so it would have to be remade. But I would normally be looking for about a millimeter and a half in thickness, just to sort of. I think that we know from studies that we've done with tooth wear, etc., that that the actual height you build into the resin restoration has a substantial impact on its survival. So I would normally be aiming for about a millimeter and a half, but once I've satisfied with the diagnosis, then I would remake the thing pretty much how Subir has described, keeping it flat on the occlusal surface and out of contact during lateral and protrusive movements.
That's the thing that initially confused me when I first read about the technique, because in my mind, only a few years qualified at the time, I thought, wait, how is that possible to build something in supra-occlusion, but then also have it out of excursions? But then when I actually did it, I found that, okay, when the patient does excurse and you mark it up and you mark up the centric stop, well, if you just get rid of the lines and keep that one dot, sometimes it just works out. But you also raise a good point, Subir, that sometimes you may need to add a canine riser. How often does it just work out, and how often would you actually have to add further anteriorly to aid that disclusion?
It'll depend on the occlusion that is at the moment, depending on the existing canine slope and the existing slopes, cuspal slopes that you have. So it's very much dependent, but it's something I feel that needs to be checked. And one thing about canine rise, which I think what my experience has been, is that sometimes when you add a canine rise, if you add it inappropriately, in other words, it's too much or it's beyond that, if you like, threshold of tolerance, then the composite tends to wear off very, very quickly. Whereas when it's within tolerance, it tends to last for a long time. So if there is some canine wear, then it works best. Then it can kind of almost dictate the fact that it's going to be all right. And if there isn't, then you might just be a little bit prepared for the fact that that composite that you've added to give that disclusion might actually chip away or wear away really, really quickly, and therefore you'll have to come back to the splint. In other words, you don't put the splint and forget about it. You have to monitor the response. So I couldn't tell you sort of a number on this, but it's quite surprising that the number of times you have to raise it on a canine rise are not that many. But it will really much depend upon whether it's a class 1, class 2, what sort of, whether it's the lateral guidance is shared by a group of teeth or not. And whether or not there is the slopes of the cusp that are involved. So it's be a combination of those factors.
So if I just pick up on that, in the actual study that we did, there was a sample of about 150 odd patients, and Subir is quite right that the number there was only 12.5% or so of the sample where we applied a canine rise. So it's a sort of my experience anecdotally as well. You don't end up placing it that frequently. And that's got it kind of benchmarked in the study data as well.
And that's good. That's what we want as GDPs. We want something quick and easy in that emergency appointment when they got a cracked tooth, and to not have to add another additional thing and explain to the patient. That would be quite helpful actually to be able to do that. So when I've done it, it has just worked out that on excursion, because of the cuspal slopes were in my favor, I was able to avoid it in lateral excursions. Now, can either of you or both of you just describe the exact protocol because a lot of times cracked teeth involve amalgam restorations. So are you aerobraiding the amalgam and then you're using, a universal bonding agent, and then you're just building it and molding it using a flat plastic, or is this under rubber dam, or is it not? Just describe the workflow and the protocol, if that's okay.
Well, for me, if I'm kind of facing an amalgam restoration, then yes, you can aerobraid the amalgam and then you put it over the top of it in the first instance, and then that would sort of give you the emergency scenario, the control, because then you would actually want that patient back, and then once it is kind of settled down and you confirm the diagnosis and the response to what the therapeutic measures that you have applied is working, that's when I would take the amalgam out and then proceed to do the restoration. Hopefully, because I've got the occlusal height, be able to restore that. So that would be my protocol if there was an amalgam in the tooth initially, because usually when you're seeing this, you're seeing it at a time of day when you want to get the patient comfortable and relieved. So you kind of I would aerobraid the amalgam and then go over the top. And if it's an MOD amalgam, I would leave of course, because it's just going over the occlusal and the outer surfaces, the amalgam stays. But then on the return visit, when we are confirming, then I would remove the amalgam and restore it accordingly. So that would be my protocol of doing it. Otherwise, if it was a tooth that was completely unrestored and there's no restoration in it, then of course it's a question of aerobraiding the enamel, making sure it's sort of nice and clean. Isolation is good, and then of course place the bonding agent and place the composite on top. My personal preference for bonding still is the 3-step technique, or you can use a 2-step technique rather than the self-etching ones. That works better in my hands. And of course, enamel bond is very predictable, as we know, and the more enamel we have, the better. And that will be my protocol for a restored or an unrestored tooth. Shamir, I don't know if you want to add something to that as well.
Yeah, I think mine's pretty much the same. I try to put a matrix band around the tooth when sort of doing the adhesive conditioning to try and help make sure that the material doesn't stick to the adjacent teeth. In terms of the contouring, just a flat plastic or composite instruments, there's no merit. There's no the old finger, the spade. There's no it's kept fairly basic. There's no real attempt to sort of make it look anything fancy. And as long as it's splints, the fracture is in the right location, and obviously has to be kept flat to try and help sort of putting those lateral loads on the tooth.
I think it's an important aspect here to also draw attention to is when you do go to, and it's quite interesting that in both my practice I find, as well as I think we found in our study, is that of course when patients get very, very comfortable with this and the occlusion equilibrates after a period of time, patients are very reluctant to have this off again, particularly if they're very, very comfortable. So you kind of have this sort of a flattish molar at the back. But if you were to restore and replace it with something like indirect restoration, once you have that space, then it's important to stress that the cuspal angles that you want to put in after on your on the indirect restoration have to be fairly free in excursive context, because you really don't want to recreate a scenario where there's any chance of these sort of forces that split the tooth or create forces like that. Again, developing in your sort of so looking at it from an aesthetic point of view, you may be compromising a little bit on the lovely cuspal angles and fissure patterns for the sake of limiting the load on that tooth, because like I mentioned before, the crack actually never heals. It's always there. You're just managing the problem on it.
I'm just going to acknowledge that Vimal's been asking some questions on the live, and I will get those very shortly. But just so in the interest of the workflow, so thanks for describing the step-by-step. Now, if you've placed this, according to the research you've done, how long do you typically need to wait before you are happy about the pulpal diagnosis and the diagnosis that the pain's now gone and you can proceed? And also, just describe what you mentioned before, Subir, about the relative axial movement. It's almost as though, in my mind, it's as though the supra-occluded restoration and the tooth itself is intruding, and then that gives you the space to add your cuspal coverage, so you can be very minimal. Is that all that's happening, or is the opposing tooth intruding a bit as well? Do we know exactly the mechanics of this? A bit like, how does a dial work, right? How does this technique work in terms of the relative axial movement?
In my view, I think there's a sort of a culmination of several things, and it's very difficult to determine how much of one happens than the other. In my opinion, I think there is an element of intrusion, extrusion that takes place posteriorly, but the very first thing that happens is a condylar repositioning element. So essentially, it's like putting a little jig in, if you like, and the first thing that happens is a condylar repositioning at the back, and then that immediately creates a bit of room. As you know, there's a little bit of room, CO and CI in a lot of patients, and that's the first thing that happens. Following that, it's a kind of a axial movement, both intrusion and extrusion, eruption over eruption of the surrounding teeth. My thinking on this, and this actually when I used to lecture about it almost 20 years ago in places like America, where this concept is can be challenging to explain and accept. The issue is really that when you have something like this, that the teeth are drifting back into what I would term as their neutral zone, and kind of reestablishing their contact according to that. And the fact that there is, if you like, an obstruction in the way, the teeth that move back into there. Now, sometimes we find that we may have pushed this technique. So in other words, too high. And so it comes almost back, but not quite. And of course, if you've done it in something in a reversible material, then you can adjust slightly in order to fine tune the equilibration in that way. But in a lot of cases, particularly if there's tooth wear, the amount of adaptation that takes place is quite surprising and quite consistent in my experience. It's very rare that it doesn't. So that would be the kind of criteria there for it. So it's a combination of movements. I think initially it's a condylar repositioning, and then it's a combination of the intrusion, extrusion of certain teeth. And of course, there is no permanent increase in the vertical of the patient at all, because it sort of reestablishes back into it. That's what Dahl's work actually kind of showed. And then you can establish that. But the proviso is that sometimes if you've just overshot the threshold on the tooth, and some of the teeth do not restore back, and the time frame you're looking at is around about the 3-month period when these sort of things happen, then you may have to adjust the occlusal of the composite. To answer your question as to when you would replace this composite, like I was saying to you, pragmatically, what happens, a lot of patients resist this change. And sometimes if they do, if you use a nano-hybrid composite, which is flat and they're not worried about the aesthetics, I have in instances left it behind and then carefully monitored and made sure there's no wear. And to be honest, it's a sort of a safe default position to be in if you kind of control the situation like that. If not, round about I would say the 2-month limit is where you would look to sort of replace it if you wanted to. But I have a lot of cases whereby once managed, very few patients do not take it to the next level.
It's a bit like some patients when you used to place the ortho bands. I know some practices still do, and then they like it and they don't want you to then place the crown or the indirect restoration because they're happy to have this ugly ortho band on, but it's got rid of their symptoms. So very much in that way. Shamir, did you want to add anything to that in terms of how long to wait in your experience?
Yeah. So in terms of our study, which is obviously based on our own experience, my sort of thinking is, normally would say to patients that, look, if you're not happy with anything, if there's symptoms, let me know straight away. Usual review period initially would be 2 weeks. And what we found in our study is actually where all the problems were, they kind of happened within those first 2 weeks. So we had about 20 patients, of which 16, they had developed irreversible pulpitis or the fracture progressed to a complete fracture. And those patients, those were identified fairly quickly. We had 4 patients who sort of expressed intolerance, and that all happened within the first 2 weeks. The rest of the sample pretty much progressed to the end of the 3-month period, and we did a review at 4 weeks and at 3 months. And again, what we kind of found is that all the sort of niggles and the adaptation, that all took place within the first 2 weeks, yet at 4 weeks, these patients were quite happy. And I suspect that may well have something to do with the adaptation, the condylar repositioning that Subir was talking about, together with some central adaptation where the patient sort of brain starts to accept that I've got something that's foreign, which is proud. And it was quite interesting to see that the change in, the sort of things that people were complaining about going from the 2 week to the 4 week. So usually in my experience, if you're going to see things wrong, you see it pretty quickly.
Yes, and I think Shamir hit upon something quite important. That is patient management, because the patient have to be carefully managed to see what to expect here. Because to them, of course, you've just explained to them that this tooth is cracked and you're making it high, and the first thought that's going through their mind is, well, this is a little bit counterproductive, isn't it? Counterintuitive rather. And it's just basically the management scenario, because of course when you make that tooth high, the forces on it, the general bite forces actually are reduced on it because of the fact that it's a sort of if you like, an interference in the occlusal system. So there is that aspect, but.
Could you describe, Subir, what you actually say to patients, if you don't mind, because you touched on it? I'd love for you to just give me like your 1-minute spiel on what you warn the patients. I mean, I know Shamir said if any symptoms arise, any issues, let me know. But is there anything else you say in terms of fine chewing movements may be affected? Take some painkillers. I don't know. What is your spiel?
My spiel in practice is, once I've identified the tooth and I kind of confirmed the diagnosis with the patient, as if this is what has happened. I think the analogy that I used about bone fracture, which a lot of patients can identify with, is quite useful, in the sense that bone fuses back together if you hold it still enough, but the tooth is not going to do that. It is a split, and it's split there for life. There's nothing you can do about it. And there's nothing, even if I make it short and you bite on it, there's nothing that will happen. It'll come back and erupt, and the same forces will apply. You're never going to stop chewing on this tooth, and that's the reality of the situation, that this is the problem that we have. And the next step of that is then to going through all the alternatives. And it's very important to point out to the patient that all the alternatives are available, including the bands, etc., etc. And then, of course, then when you look at this particular option and you're looking through the advantages and disadvantages of it, the reason why it kind of appeals to patient, that you kind of say, well, I'm going to put it on right now. I'm not going to cut your tooth. and all I'm going to do is probably not even a local that's required for me to do it. And hey, if it doesn't work, I can always reduce it. And there's that added factor. And this, of course, you have to throw into that factor of in the disadvantages is that if I use some of the other techniques, then there is a higher proportion, according to the evidence, of the pulp going necrotic or needing root canal treatment. And then, of course, when you get them on board on that, is to just be absolutely plain, honest with them. Say, you're not going to like me for this, and this is the exact words I use. I'm going to do this, and you're not going to like me for this. But there is a reason. I've just explained to you the reason I'm doing it. You're going to find it very difficult to eat and swallow and find satisfaction to eating with this. But usually in about the 2-week time, you will start to tolerate it better. And you're tending not to get pain from it, but more of an annoyance. It's not going to, if it hurts, you let me know. Okay, you give me a call and let me know straight away. If it's annoyance and it's just bugging you can't chew properly and you can't get the satisfaction of chewing, then please tolerate it. We'll see you in 2 weeks to see how you're getting on. So that's the sort of the spiel I kind of use. Is I do paint a picture of that we are in a situation which is very difficult to manage, something that is not going to heal. And of course, it's important to also point out to the patient that the situation can escalate because it's a crack. We're trying our best to hold it together, but nature is what it is, and the forces are what they are. This is going to be an issue. So that's my usual build up to it and preparing them for an uncomfortable time, but for a good cause. And that it's also the fact that it is got a reversible element to it, and I haven't cut the tooth, which is if you like the seller of it, and it's tooth colored, and it's not, then they're not looking at something that's metal. I don't know, Shamir, if you have any other added tricks with that.
No, not really. I think it's the same thing, same sort of spiel that I would normally give. And of course, where we've used the trial version to assist with the diagnosis, they'll have already had that experience of what it feels like with having something proud. And I know with some of my patients, you put it and they'll, no, I'm not having that. I'll come back or go for plan B, but I'm not having that. So I think having the trial thing does also, help with the process of attaining the consent. But the spiel is pretty much this how you've described it.
Can I ask you, Jazz? I mean, I know you have done this yourself. What we have said, is there something else you would say to this? Or how do you, when you do it for your patients, what sort of do you say?
Very much the same as what you guys have done, undersell, over deliver, explain that, you're going to hate me initially. I love saying that as well, that you're going to hate me, but it's for a better cause. The bone, the thing that you said, my old principal, Amit Mohindra in Oxford, he used to use the same thing. So I also used it was cool to see that you also communicate in the same way to patients. So very much the same. So I don't have anything to add to that, except whenever I'm explaining the different things that can happen, I do like to quote studies. So, for example, Shamir, you mentioned that in that study that you did, I think you said 16% went on to experience irreversible pulpitis or the crack deeming the tooth unrestorable. And I would say, in some studies, this could happen. So let's say 1 out of 5 times your tooth, because the crack is already quite bad, is not going to make it. And I like to just give those figures to a patient. Obviously, we can't apply studies to that individual, but when it's like a more average case, I like to just give them a few numbers about, okay, we're aiming for about this percentage of success rate. Is that a fair thing to do, Shamir, with your position in the GDC? Is that a fair thing, or is that incorrectly applying a study to an individual?
Well, I've got to say that whatever I say is my own opinion and not the GDC's view. Yes. So let's just make that clear. But I think it's fair that when you're looking at trying to attain consent, it's got to be done in a logical, balanced, accurate, and of course we're trying to do it in a scientific way. So I think it's fair to use studies. As you said, there was 16 patients out of the 150, so not quite 16%. So yeah, it was a lot less than 16%. Yeah. But if we look at the number of the overall sort of 20 patients where there were problems, effectively that's in line with what you see with most of the other protocols, which are sort of mainstream. So in terms of the success of the procedure, it is in line with what you may expect with, a direct composite onlay or an indirect composite onlay, or even a crown. However, as Subir said in the beginning, with crowns, we know roughly a fifth of these teeth go non-vital within the first 6 months. And we also know that the prognosis of a root-filled cracked tooth is also poor. Certainly that's not what we found within our study. So look, what we would say to patients, what I would say is that whatever of these techniques that you use, there is a chance that it is not going to work because we don't know how deep this crack is. And it's very possible it's hovering right near the pulp chamber or right near the sort of the periodontal ligament. And it won't matter which technique we use, thereabout, you're still going to get the same outcome. But I think I kind of do like the idea of quoting studies how you do, as long as it's articulated in a way that the patient understands and sort of can make an informed decision from that.
I think that's an important point, actually, Shamir and Zaz, that you brought up about discussing evidence. I think you should be fairly comfortable discussing evidence. Of course, the numbers might not be in ahead there, but you generally are quoting evidence, and I think that's important. And I think in the level of consent, I would go more towards Montgomery on this one rather than Bolam, where you can actually go to every little bit and it's easier to describe because it is a situation that is non-healing, and it's kind of, if you kind of stress that with the patient, that is, this ain't going to get any better, I'm just managing the problem, and make sure that they're aware of the risk, and that is the best way. And I think I often, not just in this particular instance of cracked teeth, but in a lot of treatments I'm always looking at quoting references in a way that the patient understands. In fact, just to quote you one particular patient for tooth wear, he came in and he'd read all the papers that we'd written, and so he was quoting me stuff that I'd written several years back, and which I actually didn't remember at the time, which was a bit embarrassing.
Wow.
But so our patients are very knowledgeable nowadays, so you have to be aware of that.
I mean, I have an episode out with Karina Patel all about I hate cracked teeth. And we talk about, she talks as an endodontist about management of cracked teeth. And it was a very generic cracked teeth episode. But it's one of those things where I can't emphasize enough. Now, I know you guys have done it as well, where we as a group cannot emphasize enough the importance of really over-egging the communication part in someone who's got a cracked tooth, because it's something that can be a source of stress for a dentist. That, they intervene, and then a condition that was always inevitably going to get worse because of the nature of a crack does get worse, and then the dentist ends up owning the problem rather than the patient. So those younger clinicians watching, listening, when it comes to communication and cracked teeth, you have to do your due diligence and have to spend that, even if you're going to run a couple of minutes late, just in a calm tone, explain that, okay, there is a crack, it may get worse, and that's the reality of it. We're trying our best, but there's this could very much lead to tooth loss as a worst case scenario. Just in the interest of time, we've covered so much ground, which is fantastic. I have got some questions in as well. Before we do that, I'm just going to finalize the sort of the clinical protocol element, which is, imagine you've put your direct composite splint on. It's been on a lower molar, on a lower first molar, let's say. It's been there it's got past the 2 weeks point. It hasn't dropped off. The patient's tolerating fine. You haven't needed to do any adjustment or anything. You see the patient again in 3 months, and now, would you find that, in your experience, that the bite or all the other contacts have fully established, or would you find that they're almost established but not quite? And then the second part of that question is, when you flick off or drill off that composite, how much space do you usually get? So of that 1.5 millimeters, do you find that you have got 1.5 millimeters or around about a millimeter to play with?
In my experience, it varies between patients. By around about 3 months, I'm kind of finding all the other contacts reestablished. In my experience, is the 3 months, and probably about 6 months is probably the longest I've seen it personally. But I do believe in the literature that it varies, in that. But I think after the 3 months, if I haven't established all the contacts, I'm maybe looking at adjusting the splint a little bit until I do at that kind of level. So we're looking at that. Of course, we make a note of what the occlusal contacts were before we started, and which teeth essentially hold sim stock, if I was to be pragmatic about it. As to amount of space that's left behind for the ones that we've taken away, It's about that. I think it's you kind of if you have placed a sort of a millimeter half of composite on it, then by the time if you are doing something in the sort of within the 6 months to a year limit, then you're probably not seeing a lot of wear of that composite, so you'll get a lot of that space. They'd never ever fall off because you're bonding to enamel. So that I've never had a scenario where they're actually fallen off at all, because you're bonding very well to enamel, and that's fine, and that's what you get. And of course, if you are also manage the patient, I tend to sort of prepare them for a crown, which is, or rather an onlay, not a crown, which is going to be a little bit sort of bulky on the platel and the buckle aspect because of that contour, because I really don't want to cut tooth after all of this. I'm just going to sort of polish the composite off in there. Now, the difficulty comes in how you provisionalize this in that interim that it takes you to make the indirect one. And sometimes I find I add to the opposing tooth, or you can actually, if you book it with your laboratory soon enough, then you can actually get the onlay back as soon as you can with it. Or if you've got a CAD-CAM, I guess that is it. But although I don't have an experience in CAD-CAMing it, but that's another way of doing it if you want to do it. The difficulty comes in that interim stage as to managing it for that period of time. But that's my experience on it. But like I say, a lot of patients, I've kind of, what I've done a lot of the times is actually just contoured the composite into making it look prettier, occlusively, rather than having it flat. And that's a lot of the time that I do. But that would be my observations on it. And my of choice is gold alloy, but a lot of patients don't want that. But the lithium disilicates, you're really looking to bond onto the tooth again in order to restore the integrity of the tooth. And I'll let Shamir take over now with that with that his point.
Yeah, I mean, my experience is fairly similar. If we go back to the study, in 97% of the sample, the contacts were established, and this is checked with shim stock within that 3 months. So we know that it is, with good case selection, it's fairly predictable based on this. It's quicker than what we find with anterior teeth, probably to do with the loading. And that comes back to the point that you made with the amount of space. I sometimes find that, and it's very difficult to judge whether you've actually got that 1.5 or 1 or whatever. I sometimes find that the space isn't quite as much as I would have hoped. And I suspect, and this is when I've spoken to colleagues who've used this, I suspect there may well be some element of wear of that composite, which may also mean that the contacts are establishing a lot quicker posteriorly than what we see anteriorly, where you're looking at a longer time. Certainly with the Dahl studies, they're sort of 9-month period, whereas this is a lot quicker. So I think that there may well be some wear and tear of that composite that takes place. But again, as Subir has sort of alluded to, more often than not, I will just replace it with a new direct composite, which will look a little bit nicer than what's already gone on there, rather than I've found that the provisionalization and what happens in the interim leads to more headaches. And it's a case of you sometimes learn from getting it wrong and getting your fingers burnt. So
essentially a direct composite overlay?
Yes.
Essentially. Okay. So you kind of just basically refine what you have there, because a lot of it is still bonded, especially if you bonded it correctly in the first place. And if you're not really involved in replacing an amalgam and stuff like that, then of course you can just modify the one you have placed. And that's the one with the least risk, because then you don't have to worry about provisionalization, not worry about going back to the enamel cutting, and that's the easiest way to manage it. And if need be, if you want to strengthen it, you can add a bit more composite to it on the sides, if you need to. So that I have to say that is my first preference to manage it with it, and to resist the temptation to actually remove it with something that's working. Because remember, as we said before, we're managing the problem. It's kind of the thing. The other thing to add to this whole management scenarios, and then just sharing a little bit of my experience here, is that with this scenario and the thing that I specify to my patients is that I'm taking the least step possible to get the result that I want, And so when you're managing a cracked tooth, it's important to take it in steps like that rather than go straight for the endodontics, as well as, start following the crack endodontics and doing it. Sometimes, and this allows that to happen in a more controlled way.
Great. And it's great that you mentioned that in your experiences, they very rarely come away because they're well bonded. And I think that's partly probably to do with the fact that it's usually in compressive load and it sort of hugs the tooth and it probably even cures towards the tooth in just thinking out loud. And the other thing is because you've managed the lateral excursions on it, there's going to be less tensile shear forces on it and it'll be dipping into the sort of the cuspal incline. So it very much isn't compressive. Have you ever seen any cracks split in 3 or 4, get cracks and come lost in that way?
Not on these. No, not on the ones that we bonded well. That's not been my experience. Shamir?
And in the study as well?
Yeah, I mean, I have, and in the study as well, that they're probably my ones through poor handiwork, but not cracks as such, but sort of odd, bit of marginal chipping or something like that, which is easily repaired rather than having to go in and redo the whole thing. I think the key is making sure there's enough height to this. That the height is critical, but there will be some areas where maybe towards a marginal ridge area where the height isn't quite what it should be, and you see a little bit of chipping there or whatever or something like that. But that can be readily repaired. But not a case of a complete sort of fracture where it needs to be redone. No.
Okay, great. Well, we've reached that point now in the last 13 minutes. We'll just take some questions. So if anyone's watching at the moment, either on YouTube or Facebook, and you've got any questions, if you're on YouTube, please come on Facebook because I'm not reading the YouTube comments at the moment. I'm just reading the Facebook ones. But I've got some questions from beforehand on our Facebook, on the Protrusive Dental Community Facebook group. So question 1 will go with Shweta. Wouldn't keeping a painful suspected fractured tooth high add occlusal load on the single tooth and make the periodontium sore and worsening the pain? So this is like the very classic instinctive response of a dentist who comes across your study and your technique for the first time, right? And those thoughts definitely went through my head. But I mean, Subir, you already mentioned before, it's a bit like those studies where they've introduced an interference. They found that patients were bruxing less and they were actually chewing with reduced EMG forces. Is that what you do? Is that what you think is going on here?
In my view, yes. In fact, it's not just Sweta that sort of had this heartache. Our reviews of the article, I know, on hindsight, had the same sort of, when it was published in the Journal of Dentistry, had the same sort of anxiety. And just to reassure that I did receive the written communication from quite later on after the article when research was published, as to how this phenomena doesn't have that effect that you mentioned. 2 things there. It tends not to happen because of the rationale, the reasons you mentioned, and that's what a lot of the studies are showing. And of course, this is also a technique whereby you can actually reduce it as well. So in other words, you can reduce that composite down. The main issue, the reason why it works is because you kind of eliminated the primary reason why the symptoms are there, is where the tooth flexing. So by doing that, but yes, it sounds counterintuitive, but interestingly how your own body actually protects against that load. Shamir, anything to add to that?
No, not really. I don't really want to go into the sort of physiology of it because I probably don't understand it that well. But I think when you've got something like that with the simulation of the periodontal proprioceptors, it probably triggers some kind of a reflex, a bit like what Jazz was alluding to, which therefore means that it actually isn't something that gets blasted away. It's odd, isn't it? When we put our restorations, which at times are proud by a whisker, patients will come back. Whereas with this, it's funny that you go through the consent and you go through all the spiel, and you've been through it. And on the odd occasion where you may have not done it as well, that person will call back. I think that the psychology has a big role to play as well, in that the patient knows what to expect, and therefore they're able to adapt it. But yeah, I mean, the concept, when you look at it in the way that Shweta's kind of described it, it sounds ridiculous. That why would you do that? But well, the proof is in the paper or the pudding or whatever you want to call it.
But saying that, coming back to just to mention one other study, that it's actually it's not particularly new, this concept. In fact, it was reported in the 60s in a paper. The reference, I forget on the top of my head, but essentially it's where a particular tooth was put in SUPRA-Occlusion and how essentially that the equilibration took place. So it's not really something that's absolutely new. It's been done there, as well as other studies Now, of course, the bit that's new is this effect that it's a cracked tooth. That's the main challenging bit with this bit. But to answer Sweta's question about the periodontal response, that is not unusual. It actually has been done previously and without these effects. So it's the putting it on a cracked tooth doesn't seem to affect that aspect of it at all anyway.
Great. Next question I'm going to ask is by Vimal. Let's see. I think essentially is once you come to the 3-month mark and let's say you've removed the composite and it's got an amalgam inside and you're going to remove the amalgam. This is just general crack management because everyone actually has got a different opinion here. Everyone's got a different threshold. So both of you gentlemen, how far do you chase the crack is the question from Vimal.
So, okay, I'll go first. And this is where we may differ slightly. I don't know. I tend not to chase cracks. I tend not to chase them, try to splint conservatively where possible. It's a question that I get asked all the time, especially from students and colleagues in Australia for some reason, about chasing cracks, including on teeth which are asymptomatic. I tend not to chase cracks. Once I know the diagnosis, take the amalgam out if that's required, and seal that intracoronally, and then put the extracoronal overlay on top. I tend not to chase the crack.
I actually, Shamir, I agree with you. I don't either, and I think that we come across this when I was lecturing in the States. It was a similar sort of phenomenon as in Australia. Funny enough, it's half of Australia. I don't know what it is. It's sort of half of it kind of agrees and the other half doesn't. And it's something, but it's quite controversial in the Middle East and Asian countries about this. But no, I don't chase cracks either, providing we have kind of established the symptoms are controlled and everything. I don't chase it. No.
With me, gentlemen, I went through a phase of, at the beginning, very early on in my career, thinking that was the right thing to do, chasing cracks, just because that's what I was taught by the certain mentors I had or clinicians that were teaching me. Then a chap called Pasquale Venuti, who I'm recording with on Saturday, he gave a lecture and he said that the most dangerous part of the crack is the part that you can't see. So all this bit that you're chasing, you're still never going to get to that bit where you can't see, which is the leading part of the crack. You won't even see that. So why are we weakening the tooth by chasing it? So that really was playing on my mind. And then I was with a group of dentists, very good dentists, and they sort of ostracized me for not chasing cracks. So now I've gone back to chasing cracks. So I'm glad I've met you two, and you two don't chase cracks. But there we are. We don't know really what is the best way to go, but there we are. Now we know what Subir and Shamir do. Let's see. I'm just reading some more of the questions. Just for contact points, what bands do you like to use to get good contact points? Let's say, Shamir, you're using your direct composite overlay technique. Any preference of bands to get good contacts, I think is the question, really.
Yeah, I like using the Garrison sectional matrices, which are Teflon-coated, dead soft matrices. I've been using them for quite some time now, and that's my personal preference. Certainly for doing standard, regular composite work, I've used those as well. Stopped using circumferential bands, which are not good for cracked teeth as it is anyway, a while back.
Yes, my preference is the same. It's a sectional matrix band. Garrison is the one I use as well. The only thing I would add to that, I use a lot of customized wedging. I very, very much customize the interproximal wedging of my band, whether it be with different types of wedges, whether it be PTFE tapes or more sort of similar, or sometimes even green stick, just to actually really customize that band.
Wow, I've never heard of green stick being used in that way. Pretty cool.
Yes, they're showing my age here, aren't I?
Excellent. Fine. And I've just got one last question. There are a few more from Vimal, but in the interest of time, I'm just going to ask one more before we wrap up. This is from Zain Rizvi, a really talented young dentist. He says, I found patients just don't like how it feels. What's the best way to get around it? Is there anything more than just patient management and communication and underselling and over-delivering? Or have you got any little tricks up your sleeve to make it feel more comfortable for patients?
I think the explanation as to the non-invasive nature of what works with me, in the sense that, all the other things I've got to offer are invasive, and the fact that the most likely that I have to put a local in usually swings it my way as well. They say, well, I don't have to give you a local for this one. What do you think? And the reversibility of it. And I think the combination of the reversibility and the uncertainty of the diagnosis and the managed prognosis of it kind of swings it in my favor. But yeah, I mean, mainly it's this fact that I have to say that all the other ones are very invasive. But at the end of the day, it's about informed consent, and the patient will have to consent to the treatment. So that's important. And they may, if they've made, as Shamir said, some patients don't like the idea of it being high, and so we have to do something else.
Yeah, I guess from my perspective, it's pretty much the same, other than what I can do with this is treatment there and then. Whereas before it would usually be if there's sort of an amalgam or something, I used to splint it with direct composite as an interim measure. I can't use orthodontic bands or copper rings, or it would be a provisional crown. And again, I used to really struggle with getting those teeth numbed up. I remember when 20 years ago, putting temporary crowns, provisional crowns on these teeth, trying to get these teeth numbed was really difficult. And I think patients like the idea of, well, if I get it treated now, and also the fact is, if I can't see them straight away, it may take a week or two. The crack may progress, things could get worse. And I think the selling point being that, well, something can be done now. And look, hey, if you've got problems, come back tomorrow and we can take it off and we can look at plan B. That seems to be the thing that sort of flips it. Doesn't always work, but that seems to flip it as patients sort of saying, okay, fine, well, let's give it a go.
The other thing that also is supportive is the fact of the diagnostic element. If you put the diagnostic in the patient themselves experience the completion symptoms being gone, which they did experience a second ago, that often sways them as well, because it's kind of, well, that worked, the pain is gone. And yes, it feels awkward, but as hard as I bite, it doesn't actually hurt anymore, as they were doing. Because I don't know if you ever suffered from a cracked tooth, but the pain is can be quite unnerving. Excuse the pun, unnerving sometimes, where it kind of actually shoots into the jaw, and so you're almost worried about biting, and they suddenly think, oh wow, I can actually really put pressure. And then sometimes that convinces them enough. So the diagnostic element is quite an important element, both from clinically as well as patient acceptability point of view.
I suppose the other thing that we have is that we've probably been seeing the same patients for a long time, which is a communal theme. And I think that trust element probably has a role. And that may well be, I think, Zain, you said, with a younger practitioner who may have not had that same level of history with that patient. And I think that trust thing, certainly even when using Dahl with the tooth wear cases or whatever, I think it has got a role to play.
Very fair point. Gentlemen, the time has really flown by. It's been really great to have you guys on. I really enjoyed this chat. The hour went really quickly. Just like when I asked you in February to come on to the show and we booked for November, and how quick November came by. You two are the busiest people I know. So it's really great to finally have you guys on. At the end of the show, I usually like to find out where we can learn more from you. If you have any courses, a website, because a lot of people listen and they, you know what, I like this person. If they've got anything educational, where can I read the papers, etc., etc. So, Shamir, tell us, where can we learn more from you? Are you running courses? I know you're really big on tooth wear, that kind of stuff.
Yeah, I mean, both of us teach at King's on the MSc in aesthetic dentistry. I teach at the College of Medicine and Dentistry on their MSc in restorative. I tend not to do too many courses and stuff outside of that. Yeah, we do a fair bit of writing. We've written 2 textbooks as well. Subir is probably does a lot more hands-on stuff than what I do.
Yeah, I mean, apart from King's, I've just launched my own diploma and master's program with the University of Portsmouth. So we're recruiting for March of next year. So if anybody's interested, do let me know. This is a master's in advanced aesthetic and restorative dentistry program, which you can actually do a diploma in with us, where I teach along with my faculty. And then you can take it to a master's with the University of Portsmouth. If you want a master's in aesthetic dentistry from King's, of course, I manage that program as well. I've stopped doing shorter courses. I do lectures here, there, as you've mentioned, Jazz. But I prefer structured learning. I always, I'm always a big advocate of that. I think the shorter courses fit very well after you've got the sort of the second foundation of the postgraduate structured learning. I think so. You have a structured learning at undergraduate level, then you have a structured learning at postgraduate level, whether it be towards specialist or in general practice, and then from there on, you can really then add to your skills by adding short courses, going around the world and listening to people speak. So I'm a big proponent of structured learning at the postgraduate level. I think that has to get the whole picture. Whenever I run short courses, it's very difficult to give the full picture. So we've always kind of done that. And I think that'd be my big thing on it. Do it structured. And just invest time. It's worth it. It's sort of pays off in the end.
I still really want you to think of IPL 2022, and if you can do it in Punjab and not in Mumbai, that'll be even better. So I can be there to watch the Kings 11 Punjab play. But yeah, gentlemen, it's been an absolute pleasure to have you on. You've been absolutely fantastic. Really great to learn from you both. I'm just going to end the live video on Facebook, but goodbye, Facebook people. Amazing. So yeah, that was absolutely fantastic. I really enjoyed myself. Thanks so much for coming on, gents. So there we have it. This crazy, weird technique called the Direct Composite Splint Technique for managing cracked teeth. Check out the papers. I would encourage you to read more about it before you actually do it. And it may even save you from a tricky situation, even if you just use it diagnostically, i.e. you suspect there's a cracked tooth, you then place the composite on top, and now the pain goes away. That is a diagnostic event. So even if you don't think you're going to go the full hog and use this technique because it's too controversial for you, I think you can still use it as a diagnostic aid. Anyway, hope you enjoyed that, and I'll catch you in episode 99. Oh my goodness, we're approaching 100. I've got something special planned for 100. You knew I would, right? You knew I would. Okay. Anyway, I'll catch you soon. Same time, same place. Take care.